Hi, I'm Dr. Green. Welcome to MedTwice. Today I want to talk about Vbac, vaginal birth after C-section, also called TOLAC, trial of labor after C-section. And the bottom line is, for many women that have had one previous C-section, trying to have a vaginal delivery after that C-section is a really good idea. It's low risk and has a lot of benefits. But in order to do it safely, all the right things have to be in place. Now, I made a video on Vbac about 7 years ago, and you'll find that if you search through our MedTwice channel. A lot of things have changed in 7 years, and there were several comments in the last couple of weeks asking questions about Vbac, and also someone suggested that we make a new video about Vbac. We read your comments, we take them seriously, and I think that's a great suggestion. So today we're going to do a new Vbac video that's going to be updated with sort of the latest thinking and the latest trends in Vbac. So let's talk about this naming thing first. Vbac is what we've always called this, vaginal birth after C-section. But over the last few years, the sort of powers that be have decided to change the nomenclature, the naming, to TOLAC, which is trial of labor after C-section. To me, that's kind of a cup half empty way of looking at it. I mean, I think if you're going to try to have a baby vaginally, we should assume that you're going to have success. So I still go with vaginal birth after C-section or Vbac. I think those people with kind of gray hair like me tend to talk about Vbac. The young ones that are just fresh out of residency, they tend to use the phrase TOLAC. But you may hear both phrases. They really mean exactly the same thing, but just to eliminate that confusion. And so the idea of having a Vbac can be a very good idea. I mean, you've been through a C-section before, you know that that can be pretty painful. There can be some significant recovery. And we know that if you have the baby vaginally, for most women, it's less risk to the woman, and the recovery is a lot more simple. So there are some definite benefits to having a Vbac. There are also risks to having a Vbac. The problem is whenever we have scar tissue, that scar tissue isn't as strong as what the natural tissue was. And so in order to do a C-section, we have to make an incision through the uterine tissue, through the uterus. And so that scar that gets formed in the uterus isn't as strong as the normal uterine tissue. And so there's a risk of that scar rupturing or opening during labor. If that happens, it can cause a lot of problems because you now have a big hole in your uterus. It's possible for the baby to be expelled through that hole, and the baby's now no longer in your uterus but free in the abdominal cavity. Furthermore, if the placenta gets damaged or ruptured as well, the baby's not getting blood flow, and of course that can be a disaster. And so there have been some issues, and there is a very small risk of a uterine rupture which can cause damage to the baby. The baby could even die from that. The other problem is that the uterus has a tremendous amount of blood flow that's going through it about the time that you're going to deliver. So if you look at a uterus at the time of delivery, there's about 500 cc's of blood that flows through it every minute. That means that if all that blood were to just dump out into your abdominal cavity, in other words, if there was a complete loss of the blood that's going through the uterus, you could bleed to death in a matter of minutes. And so there is also a risk to your life if there's a uterine rupture. That's pretty scary, and that's what gives all of us a little bit of hesitation with Vbac. And I think that's where a lot of this change and controversy is coming from. How do we manage it safely? Is it possible to do a Vbac and minimize the risk so that the benefits of delivering vaginally outweigh the risks of having a bad outcome? And it turns out that there probably are. If you look at what's been going on over the last years with Vbac, there's been this huge pendulum swing over the years about what we do with a woman after C-section and what we recommend. Back in the early days, when C-sections were becoming more and more popular, there was this idea, once a C-section, always a C-section. So it was thought that it was never safe to allow a woman to deliver vaginally after having had a C-section. And so if the woman got pregnant again, she just had to have a repeat C-section, another C-section every time. People started looking into this, and it turned out that actually it was rare for a uterus to rupture. And so more and more people were doing Vbacs. And it got to the point really in the late 90s or even the early 2000s where we were almost more than encouraging women, and in some situations we were sort of not offering a repeat C-section, but really asking every woman to try to have a vaginal delivery after C-section. that was probably way too aggressive. And so there was pushback on that. And the pendulum swung way over to the other side. And after there were a few problems, and unfortunately, I hate to say this, but a few bad lawsuits, people started changing their ideas. And it got to the point where women weren't allowed to VBAC at all. Doctors were refusing to do it. Hospitals were refusing to allow it. And VBACs basically became a non-option for most women. And we were back to once a C-section, always a C-section. That was also way too aggressive on the other side. Over the last several years, the pendulum has been swinging back. I personally don't think it's swung back far enough yet, but it is getting more towards that middle ground where doctors are more willing to participate in a VBAC, and hospitals are starting to allow it again. But they're doing it in a much more safe way. And so I think, some of this change has been good for women because now we're able to offer VBACs in most situations in a much safer way than we were before. So that's kind of the history of how this has swung back and forth. And that's been a big change since 7 years ago when I discussed this with you last. So how do we decrease the risk of a complication, particularly uterine rupture, when one tries to have a vaginal delivery after having had a C-section? Well, one thing is to address whether the woman is a safe candidate, whether there's a good candidate. So we can look at your history and see things about you and your past that can tell us what your chances of are success, what your chances of actually having that vaginal birth if you attempt it, and also what the risk is. One of the things that we look at is how many C-sections you've had. We know that if you've had one C-section in the past, your risk of uterine rupture is very low. It's 1% or less, which is really pretty small. However, if you've had 2 C-sections, that risk goes up to about 5%. So you've at least 5 times increased the risk, and that 5% is a pretty high risk. I personally don't recommend trying a vaginal delivery after 2 C-sections because I think the risk is too high to justify with the benefit of a vaginal delivery. There are some doctors that disagree with me, and so it is possible to find somebody that would be willing to attempt a VBAC with you after 2 C-sections. I personally think it's not a good idea. More than 2 C-sections, that risk gets really, really high, and I don't think any reasonable doctor would recommend trying to deliver you vaginally after multiple C-sections, 3, 4, 5, or more C-sections. That risk is really, really high, and I would highly discourage you from even thinking about that. So the first thing is, how many C-sections have we had? 1 C-section, probably a good candidate. More than that, not so much. The other question is, how was the C-section performed? There's sort of 2 ways to make an incision in the uterus. One is what's called a transverse incision, which is a crossways, and the other is a vertical incision, which is up and down. Most C-sections are done transverse. They're done across for several reasons. First of all, quite honestly, it's easier to perform and it's much easier to repair to sew it back up when you're done. There's also a lot less risk of bleeding. And importantly for this conversation, the scar heals much better, and it's in an area of the uterus that doesn't have as much force on it during labor, so it's a lot safer to try to VBAC if the incision is done in the transverse way rather than the vertical way. So that's the other thing, is that we need to make sure that that previous C-section was done transversely and not vertically. How will you know? Well, most likely it was transverse because that's the way most C-sections are done. You can always request the operative note, which is a note where somebody describes exactly how they did the C-section from your C-section so that your doctor can review that with you. What are things that would force somebody to do a vertical C-section? So in other words, what about your previous C-section might be a red flag? Hey, maybe they did this the other way. In situations where the baby is very, very small, let's say that you had a 24 or 26 week delivery, that uterus is very thin, and there's usually or often not enough room to go transverse. In that case, you have to go vertically. So a C-section done for very premature babies tend to be vertical. So that would be one thing that you would worry about. The other thing would be a difficult delivery or a difficult C-section. Sometimes we start with a transverse incision, but there just isn't enough room to get the baby out safely, and then we have to do what's called a T incision, where we start transverse and then we make a vertical incision. A T incision has the same risk as a vertical incision, so a previous C-section with a T incision, you really should not try to VBAC after that. So that's another thing. One C-section done transversely, which is most likely how they did it. There's another issue that's very important, and that is why you had the C-section. And that may seem kind of silly, but it actually really helps predict how likely you are to deliver vaginally, to successfully do a VBAC. We know that if you had a C-section for what we call a non-reoccurring thing, what that means is that, let's say the baby was breech and you never had the opportunity to labor and you had a C-section for that reason. Or let's say that everything was going fine and then all of a sudden the baby got sick or the baby's heart rate went down and they had to do an emergency C-section for that reason. For something like that, your chance of having a VBAC successfully, of being able to deliver vaginally after a C-section, is about 80%. That's really very good. But on the other hand, let's say that you labored, you got to completely dilated, you pushed, and you just couldn't get the baby out. The baby was too big for your pelvis, or your pelvis was too small for the baby, and they had to do a C-section for that reason. Your chance of successfully delivering vaginally after a C-section in that situation is only about 20%. That's a huge difference. So my recommendation is that, 80%, that's a pretty good success rate and probably worth the small risk for the benefit that you're going to get. But if your chance of success is only 20%, you're still taking all that risk, but you're unlikely to get any of the benefit. There's an 80% chance you're going to have a C-section anyway, and so you've accepted the risk without the benefit. Probably not a great idea to attempt a VBAC. Now, there's situations in between. So let's say that you labored and you got to 5, 6, 7 centimeters, and then you kind of stalled out. Well, there you have about a 50-50 chance of successfully having a vaginal delivery after C-section. If you were induced and they just couldn't get you into labor, that doesn't count as laboring. You're still at about that 80%. So those are some different scenarios. If you got to complete, pushed, still couldn't deliver the baby, a VBAC may not be the wisest choice for you. If, on the other hand, you never really got into labor, or your C-section was done because of baby issues, not because of size issues, then I think your chances of VBACing are excellent, and it may be worth the attempt. Another important thing is that you're motivated to do this. It's really important that you're the one that wants to try to deliver vaginally. Don't let your doctor talk you into it. Don't let your family talk you into it. Don't let your friends talk you into it. You're the one that's accepting the risk. You're the one that's gaining the benefit. It's really important that you're motivated, and this is something that you want to do. Another way to decrease the risk of a problem is to wait a little bit longer before you have your next child. We know that it takes about a year before scar tissue has its full strength. So if you wait at least a year or more to get pregnant after your C-section, that scar tissue in the uterus is going to be a lot stronger, and it's much less likely that you're going to have a uterine rupture. So spacing your kids out a little bit more, at least a year before you get pregnant after a C-section, is another way to decrease your risk. So those are things that we look at as far as your history, your motivation, how long it's been since you had your C-section, that all tell us sort of some things about the risks that you're going to experience from trying to VBAC. What are some of the things that need to be in place to do this safely? First of all, you need a doctor that's willing to do this. So you need an obstetrician that is willing and is skilled at doing VBACs. What that really means is they're going to need to be willing to be in the hospital or have somebody in the hospital for them that can do an emergency C-section if there's a problem. So here's the thing. If you're laboring in the hospital and your uterus were to rupture, if they can move very quickly and get you to the operating room in a matter of minutes and do an emergency C-section, most of the time we can get the baby out before there's damage to the baby or really significant risk to you. If there's a significant delay in getting you to the operating room, at that point the baby may be injured or may even pass away before we can get the baby safely out. And the longer we wait, the more risk there is to your health and even to your life. And so it's really important that everything is in place so that if there's a problem, it can be recognized and acted on immediately to increase the chance of a healthy baby and a healthy mom, which is the outcome everybody wants. So you need a doctor that's willing to do it, and you need a doctor in the hospital every minute that you're laboring against a previous scar. So there's two ways to do that. One is that your doctor just commits that when you're in labor, they're going to sit in the hospital and wait for you to deliver. A more common way to do it is that many hospitals now are hiring what's called OB hospitalists or laborists. Those are obstetricians that are hired to live in the hospital, and they're there for emergencies. Usually they do 24-hour shifts and they trade off every day, and so that there's always someone there, even if it's not your personal doctor, but your doctor signs out to them, calls them up and says, hey, I have a lady who's attempting a VBAC, and they know you're there, so that if there's a problem, you have somebody living in the hospital that can move very quickly. You also need an anesthesiologist in the same situation. So you need an anesthesiologist in the hospital that's available to help with the C-section, to put you to sleep or give you anesthesia so that C-section can happen immediately. And finally, you need an operating room and operating room staff that are available, again, to immediately do a C-section. This is why I highly discourage someone from trying to VBAC outside of a hospital. This is something that you should not try to do in a birth center or in your house, because if there's a problem, there's not going to be time to get you to the operating room by the time you call 911 or you drive to the hospital and they get you to the operating room. Most likely your baby is not going to be alive, and there's a real risk that you won't be alive either. This is not a situation where you should try to deliver outside of a hospital. It's very dangerous and it's a big mistake. So if you want to try and do a VBAC, you need a situation in place that's dedicated to taking care of your emergency immediately if it should happen. So that's a really important piece of the puzzle. And honestly, that's part of the pendulum swing that's been a little bit slower to get back to the right position. More and more hospitals are providing situations that are safe, and more obstetricians are either agreeing to be in the hospital, or at least having somebody in the hospital that they're able to sign out to keep you safe. But that's something that you need to ask and you need to make sure is in place. So that's another important thing. So for most women that have had a previous C-section and only had one C-section, and that C-section was done transversely, which again is most C-sections, a VBAC can be a great alternative. Again, there needs to be a hospital and a doctor, an anesthesiologist, and OR staff available if there's a problem to immediately take care of you. But in that situation, VBACs can be very safe and provide a lot of benefit for you. You have much less pain. You have a much shorter recovery, so you can enjoy your baby more right away. And the other big thing is that if you want to have a large family, you can have as many VBACs as you want, but each C-section carries greater and greater risk. So if you want a dozen kids and you had to have a C-section because your baby was breached the first time, then you really want to try to VBAC, because that will decrease your risk over time to have as many children as you want. So that's everything that's new with VBAC. If you have questions or comments, please put them in the comment section. We will read those. And if you like this material, please like our video. And you might want to subscribe to our channel. We have lots of great videos that may be of interest to you. Thank you.
Medtwice.com